So as Anne-Marie said, my name's Jennifer Cleland. Most people just call me Jen. And I've worked a lot in the last years on medical careers decision-making in doctors mostly, but it is worth giving a little bit of background. So as Anne-Marie said, I'm a clinical psychologist by training. So I trained in the NHS and then worked as a clinical psychologist for about 12 years, but all the time juggling that with being a medical educator and doing education and respiratory disease research. And over time, my clinical commitment went down and my university commitment went up. But as a psychologist, it was quite interesting moving into medical school. I didn't really know what a psychologist was or what a psychologist did, which actually had quite a lot of advantages because I couldn't be easily pigeonholed. So working mostly in medical education, but I did do a lot of work with pharmacy colleagues over the years, particularly looking at medicine, over-the-counter medicine and training medicine counter assistants. But I am now based in Singapore, which has got slightly different climate from Scotland. But I was particularly delighted to be invited to speak at this conference because I did actually do my PhD at Queen's University Belfast quite a long time ago. I kind of at the end of the Troubles, there were still quite a lot of things going on then, but it was a really good place to do a PhD and great fun. And of course, travelled around Southern Ireland or Ireland quite often for conferences and things like that. But then after all the training, I worked in Aberdeen. So it's the most northerly medical school in Scotland. And it has some interesting issues because our catchment area was remote and rural Scotland. Basically, we covered the Highlands, we covered the islands. The Aberdeen city itself is quite small and it's surrounded by farmland. And if it wasn't for the oil industry, it'd be a really provincial city. Because of the oil industry, it was kind of weird, you know, it was culturally diverse, but sitting up here in the north of Scotland and surrounded by farms and sheep and fishing and things like that, actually a very nice place to work. But it did open my eyes to some of the issues with healthcare provision outside the central belt of Scotland, outside the urban areas. But perhaps because Aberdeen is relatively remote, there was a lot going on about 10, 15 years ago, a lot of scandals or a lot of concern about the nature of medical training, not so much at medical degree level, but thereafter. And there was numerous reports, the Greenaway report, the KEOG report, European Working Time Directive came in, the Tempo report. And there was just a feeling that things weren't all right in the house. And things were particularly not all right in Aberdeen, to be honest, linked to the fact that we were remote and rural. So I'm using a particular example, which was from emergency medicine. Our emergency medicine department was imploding about 12 years ago. They weren't meeting their clinical outcomes, but it was a really, really unhappy place and lots of trainees were leaving. So these were people who had obtained their national training number to become an emergency medicine physician. You know, difficult thing to get, but they hated it so much they actually quit training and often went to do something different like general practice. And, you know, was it the nature of the work? Was it the nature of the department? What was going on? But it was unhappy, it was understaffed. And because it was unhappy and understaffed, then it had real problems recruiting people as well as retaining them. So then it became more unhappy and even more understaffed. So there's this vicious circle of what was going on, and it certainly hit the Scottish Government press and there was lots of attention. So that was kind of where I'm starting from. And my colleague and I spent a lot of time talking about these issues. My colleague Peter Johnson, he's postgraduate and I was based undergraduate. So together we had this kind of overview of what was going on. And we thought, well, what can we do about this? There was a lot of chat at the time about how, what's the contemporary word, our new residents, our graduating medical students were snowflakes, you know, that they didn't understand, you know, what they were getting into, and they weren't used to, you know, hard work and blah, 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 and all these things that I'm sure you've heard about your own trainees. But, you know, there had to be something a bit more to it than that. So we started looking at what influenced medical careers decision making. So I've put this slide up because I think things are slightly different for you, but I'm not entirely sure. So just bear with me for a second so you get the context. So students, you know, high selection states get into medical school, then they go into foundation training. It's mandatory for 2 years. You're fully registered at the end of year 1. You can't apply for specialty training until year 2. And then there are various pathways. You can go into general practice or you can go into one of the other specialties, and different specialties have different ways of doing things in terms of time of training and exactly how training is set up, whether it's run through or decoupled. And then if that's all successful, you go get your certificate of completion of training and you go on to become a consultant, or you may choose not to and take a non-consultant career post. So there's lots of kind of pinch points in the system where people may take a decision to do something else or to walk. And bearing in mind that typically if you get into medical school, you're going to graduate from medical school. The real pinch point is at the beginning. And the pinch points later on roll out in different ways. It's often about not getting into the specialty that you want, but you're still a doctor. So we knew from the literature that there's loads of influences in medical careers decision making, and I invite you to think of this list in relation to your own discipline. So gender, individual preferences, experience of a specialty or a locality when you're an undergraduate, exposure to things. Increasingly over the last couple of decades, a wish for work-life balance. And the medical school itself is also known to be an influence on on career destinations. So some medical schools will produce far more specialists, some other medical schools far more GPs. So obviously the curriculum, the hidden curriculum, the informal curriculum influence decisions. But the gender was quite interesting for me because clinical psychology is full of women. So they recruit about 95% female into clinical psychology, and everybody's most people are a certain age when they go in, so they qualify and then they go on maternity leave, and they wonder why it's difficult to keep up staffing levels. But the interesting thing also is this exposure and experience of a specialty, and I'm going to come back to that later. So just moving on, sorry. Don't you just love it when your computer jams? Okay, so when we first started looking at this, we thought, well, okay, so there's residents quitting and people are changing direction, but how early does this start? And let's have a look at the medical students. When are they formulating their career decisions? And do these change during medical school, or do people come in going, I'm going to be a paediatric surgeon, and they leave saying, I'm going to be a paediatric surgeon? So we did some surveys of medical students across Scotland, and we developed these questions from the literature and asked what was important in when they were making a career decision going forward. So, some of these are relatively obvious. Your aptitude and skills, potential earnings, work-life balance, career prospect, the partner's career, whether you like a lot of patient contact, whether you like to have continuity of patient contact, but also where something is, transportation links and so on, the practicalities as well as the kind of the nature of the job, because jobs aren't just about the job, it's also about where they are and how it fits with your lifestyle. So we did lots of this work, and then we thought, well, this is all very interesting, but actually what was happening is many of these students were ticking everything is extremely important. We're like, oh, that doesn't really help us in workforce planning, that everything's important. How can we manage everything? So we thought we're going to have to be a bit cleverer about how we collect data and have a look at push and pull factors. So instead of everything being important, what pulls you towards a particular specialty, a particular place to work, and what pushes you away from it? So there's attractors, and then there's things that push you away. And again, maybe stop and reflect about some of your own career decisions. These are what we balance up all the time. And in fact, we don't just balance it up with career decision making. We have push-pull factors for all sorts of things, like buying a new car or getting a new phone or going on holiday. It's all that kind of weighing up the pros and cons. So we thought, well, let's move on. Let's try and get this field on, because it was a field that was absolutely dominated by the local survey, the survey that had been made up locally and then was given to all the residents or all the students. And in fairness, that's what we did. So I'm not knocking it too much, but the field had to move on. You can't just have little surveys from all over the place to pull together a bigger picture of what's happening. So we got in thrall with the health economics unit in Aberdeen. So they're a kind of world-renowned unit. And one of their areas of specialty is this thing called a discrete choice experiment. And I remember as a patient being asked to fill one in for my general practice. I can't remember what it was about, but I did remember it was very long and took ages. But this is a non-careers example for you. And I think this was the kind of thing that I had to fill in as a patient. So what would you prefer? And it mixes up options. So if you look here, there's different types of reminder type. There's different timings of when you get your reminder. There's different content in your reminder. And then there's a different number of reminders. And you have to decide which one suits you best, which one works for you. So maybe you fancy the, one reminder and you want it by social media. And you want it plenty of time in advance so you can sort out your diary. Or maybe you want the directions, or maybe you want it a couple of weeks before. Everyone is different, and some people prefer a phone call, some people prefer social media, some people prefer Gmail. So what are your preferences? And by putting things together, you can actually model what most people prefer, or what and tease out the 4 things, the reminder types, the timing, etc., etc. Tease out what's actually most important for most people. So we were looking at medical careers decision making and what's most important. So I'm not going to, we looked at the literature, we did an online qualitative survey, which was actually very interesting. We just did 6 questions or 2 questions. Name 3 things that are important to you most important to you in your career, making a decision about your career. And then name 3 things that are least important. Really simple. We got loads of responses. We got about 500 responses, and some just had put 1 or 2 words down. Some had written an essay for things that I do not want, what's least important, what I don't want in my medical career. We got loads of interesting information. We also had some focus group discussions and developed the questions, tested them out, and so on, did some pilot testing. So that took a while. But what we ended up with were these tested questions. So we looked at familiarity with the hospital unit. And if you think that foundation year doctors or interns, we discovered that they quite like going back to where they did on some of their undergraduate because of familiarity, for example. Where the hospital is, where the rotation is in terms of geography, whether there were some opportunities for their partners, their spouse. I'm going to skip over potential earnings and come back to that. There's also the reputation of the unit and working conditions. Now, potential earnings didn't actually come into it, but because this is an economics model, we put in potential earnings because that gave us a metric to measure the other things against. And then the questions are formulated like this, so that everything's mixed up. And we actually had 18 questions, but that takes quite a long time to do, so we managed to split them into 9 each. And we sent it to students, stage 3, we sent this to students in the 5 medical schools at that time, and did it on paper. And we basically trekked around the country getting students to fill these in. And then we sent it out online to trainees across Scotland plus the north of England. So in terms of results, we found that for final year medical students, the things that were most important to them when thinking about their next career choice, which was where they wanted to do their foundation programme, the most important thing to them was the working conditions of the unit. The second most important thing was the reputation of the unit. And we also found out through other ways and means that they found out about the reputation of a unit through word of mouth. So at that point in time, NHS Education for Scotland, who they look after all the postgraduate all the healthcare professions postgraduate training, We were spending an absolute fortune on careers fairs for people to come to Edinburgh and walk around stalls and ask about specialties and ask about places of working. Complete waste of money, because actually what they did was they looked what other people were talking about on Twitter, on Facebook, they phoned a friend, they asked around, it was all word of mouth. And they asked about where somewhere was like to work, what was the reputation. So it wasn't the academic reputation as such, it was the reputation as a place to work. And then we did the medical students, but then we also looked at the trainees, and 3 things came out top. One was location. I showed this slide once to some colleagues in Inverness, which is really very rural, and they assumed that the slide on the right-hand side, the mountains and the loch, was the more desirable place to live. But actually, Glasgow, the urban centres are always the more popular places to live, and I'm sure that reflects your countries as well. We've got the working conditions, and interestingly, opportunities for partners and spouse. So these respondents are a bit older than medical students, obviously. They're in their mid to late 20s, so probably more at the stage of life where they've got a partner, they might be thinking of schools and kids and partners' jobs, more so than your average sort of 22, 23-year-old. So in terms of what was most valued, again, the working conditions. How good was that place to work? Opportunities for partners and spouse came quite near to that, and locality was next. And at this point in time in the medical literature, it was all about location, location, location. All the discussions where it's all about where something is. And we were able to say to the policymakers and the Scottish Government, well, hang on, there's a little bit more to it than that. It's not just about where a hospital is or where a general practice is, or a district general. It's also about what's it like to work in, and what are the facilities around about. And that's a tricky one, because as a healthcare provider, how can you influence jobs for spouses if they're not healthcare, schools for kids and so on? And that's maybe something that we can reflect on. And then we thought, well, okay, and then things changed a bit more. We're having huge problems with our foundation doctors taking time out of training between foundation and applying for specialty training. And that was considered a big issue. And you can see here, sorry, the figures stop at 2019. I couldn't find the more recent ones, but I know mentally that it's dropped below, I know it's dropped below 30%. So, more than 2/3 went straight from foundation training to specialty training in 2011. And as I say, the most recent figures are under 30%. So it is now the norm to take a year out of training after foundation to usually do an on-training post to learn a bit more about a specialty you want to work in. Some people go overseas, but actually the most common things are doing other jobs in the NHS or in academia. So we were very sneaky here. We managed to link in with the UK destination survey that's sent to all foundation doctors. So our discrete choice experiment, which was a new version, I'll show you in a minute, went out with this destination survey, which is mandatory to complete. So although we had made it perfectly clear that the research bit was not mandatory, because we got past that first hurdle of people actually opening an email before they deleted it, and got quite remarkable response rates for a survey. So what do foundation 2 doctors value? As I say, this was ever so slightly different, and I'm sorry, I thought I had a slide spelling it out, but we really broke down the working conditions. We had some more focus groups. We talked to foundation doctors, and they teased out working conditions into a number of different variables. So we still had location, but instead of just working conditions, we had the culture of the working and learning environment. We also had excellent working conditions. So these are different because the culture was like how pleasant the place was to work, what colleagues were like, that side of things, whereas the working conditions was about rotas and shifts and the practicalities of the thing. They also teased out that they wanted excellent opportunities to expand their professional development. So they wanted the right location, a good culture in their department, they wanted excellent working conditions, and they wanted excellent opportunities to expand their professional development. So quite a lot to ask for in today's NHS. And I put this up because I found this in the BMJ just as we were writing up the results of these studies, and it made me laugh so much because it's like, I thought, have these people seen our data? Have they, have they managed to break into our database? Because this ad, and I photocopied it from the BMJ, that's why it's so fuzzy, but it just hit every button. We're a dynamic team who offer excellent training in a supportive environment, as well as having an emphasis on work-life balance. And if you look further down, apart from obviously excellent salary and good working conditions, they also talk about on-site emergency specialists. So that's the supervisory support, as opposed to juniors in the workplace feeling that there isn't a senior they can go to. So it just amused me because it was so spot on in terms of the things we were finding. And at that point in time, there was still quite an exodus of Foundation 2 doctors to work in Australia, and you can see why. So this learning environment seemed really important. And so we went and we did a few more qualitative studies, again, looking at the Foundation 2 doctors. And I won't read every word here, but I've highlighted the important ones. So, somebody was saying, oh, really good senior support, proactive supervisor, lots of constructive criticism, enthusiasm, and all of this makes me feel valued. They make opportunities for me, they take an interest in me, it's great. And then we had another participant, and they had a completely different experience. I found the foundation experience disappointing, not enjoyed it as a profession or a job. I feel undervalued. I don't feel respected or considered. I don't feel my work is recognised and devalued, and so on and so forth. And although we weren't looking at outcomes, this was a qualitative study, I can tell you that this second individual did quit medicine. So, there are consequences of having negative experiences in the workplace. And we were also able to put in some questions into the National Training Survey, and all Foundation doctors, all residents across the UK fill this in. So we added in 10 questions in 2015, and this positive clinical experience kept coming out as important. And it's consistently the most important factor. So we actually, one of our priorities is to go in and look at the last 7 years worth of data to just get even more of a handle on what's going on in terms of medical career, what's influencing medical careers decision making. It's now a massive data set. Sorry, just having a little jam there. Okay, so again, if we think of the influence of the clinical learning environment, lots and lots of other work, including our own, has looked at the associations between learners' perception of the clinical environment and their learning, the development of professionalism, achievement, burnout and well-being, very topical at the moment, and career choice. So there's something about the learning environment. There's a lot that's important. This is the thing that's important in terms of experience. But what is it? Because we talk about the clinical learning environment and you think, ooh, where do we start? But it's made up of not numerous things. So we've got the physical surroundings, the systems and structures, the organisational culture, the people, the relationships between people, the relationships between staff and patients. But actually, if you look at the list, you'll see that patients are not the issue. It's the workplace, and it's the staff, and it's the colleagues, and it's the systems, far, 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 far more than the patients. And it's not, yes, we can have difficult patients and challenging patients, but that's not what demoralizes people in the workplace. So I got a few concluding thoughts because I'm aware of time. So I think that today's students and newly qualified colleagues want a fulfilled and well-balanced working life. They want supported and trained. They want to feel valued and part of the team. And they make decisions based on their past experiences and word of mouth. So if somebody has a bad reputation in your hospital, then they may not want to come and work there, and they will tell others that it's not a good place to come and work. The word of mouth, as I said earlier, is important. I want to finish by going back to our emergency medicine department. So it really was in disarray, to put it politely, 10, 12 years ago. So they had to sit down and think, what are we doing? What can we do to improve things? And they addressed things at a couple of levels. One was a systems level. the biggest bugbear for the trainees was what they perceived as a really unfair rota system. That, trainee A said, well, I'm always getting the Friday night shifts. That's not very good. And trainee B was always getting the daytime shifts, and people weren't being able to get time off even if they put their requests in time. And there was just a sense that it was really unfair, and it was being managed by a manager. There was no consultation. It was just somebody putting names in boxes. So one of the systemic changes they did was a consultant and a resident became co-rota coordinators, and they tried to do a fair system. So yes, all the shifts had to be covered, but they tried to do it fairly, and that really helped. That really helped kind of the culture and the atmosphere, the combination of working together and trying to be fair and involving the residents, and a bit more of a sense of everybody in it together and working together. And I won't go into all the nuances, but then they did things that were about the culture. So the slice of cake in the corner is, remember Great British Bake Off? They started sort of a Great British Bake Off competition and tried to have a department coffee time once every couple of weeks. And of course, not everybody can make these things, but it was just something that was about improving the culture and the relationships in the department and adding a little bit of competition as well. So the detail is in the slide, but this took years to change, but then it became a very positive working environment where people wanted to come and work. So I shall stop there. I think I'm too time. I shall stop sharing and perhaps take some questions, hopefully.
Lovely.
The last slide. Somebody wants the last slide again?
Oh. Is it the second to last with the conclusions and your?
All right, not the
lovely
surfing emergency medicine team. Okay.
Yes, yeah. That was wonderful. I mean, thanks so much for that, Jen. So comprehensive and addressing multiple layers of what is a very complex issue. I mean, I suppose to start there, and we have a couple of questions, and one there mimicking my own thoughts. I suppose when we think of all of those very high level issues, and you mention, the likes of the organizational culture and the reputation, that some of these are factors that, are very much, that take a long time to build or to influence and change for the onlooker. And just in terms of maybe what managers and what practitioners on the ground, when they have students, what do you think are kind of some of the principal actions that they can take to contribute towards those positive perceptions?
Mm-hmm. One of the things is, what can you control? Because we're all very well aware that there's things in our working environment that are beyond our control. You can't change the politics. We can't change the fact that the NHS is underfunded. So it's about what can you change in that area that you've got some control over. And the things, I haven't presented it, but the things we hear from students and we see in the literature, it is about feeling supported and feeling valued. And one of the things is new people feeling welcome when they come to a department. And it sounds minor, but it's not. A feeling that somebody's actually expecting them. I mean, how often have students pitched up and people are like, oh God, we didn't know you were coming today. Right, okay, give us a bit of time to sort out what to do with you. That happens all the time. But if it was you, you'd be thinking, oh, right, okay. So that making people feel welcome, being a little bit organized, telling them where things are and how things work around the place, that you can give them a printout of these are the rotas, but there's that kind of, what's the word? Intrinsic knowledge that you build up about how things are done around here. That side of things is very important. So making them feel welcome and giving them some of the insider information that they need to work the job. And if you can, assigning them, making sure that they know what they're meant to do and who they're meant to be with and where they're meant to be at what time. Because there really is nothing worse as a learner as wandering around thinking, where am I meant to be? And all the time thinking that you're going to be in trouble. So, put yourself back, think back to your own training days. A lot of it is about feeling welcome and being supported and looked after.
Yeah.
But you have to support your educators as well, because of course one of the big issues is the service training tension. Have you got, you know, we take trainees, but you know, how many people have sufficient protected time to do that?
Absolutely, yeah. It's and just seeing comments come in there around that time piece, and wonderful. I think that, you know, a lot can be achieved through some really practical planning and organization, and putting those kind of very sensible logistics in place to support a person to engage with the workplace. And I suppose just a question here kind of around, how does the medical profession address time for training at all levels of staff? So perhaps where you have more junior members of staff who are qualified and are needed to maybe support the training of students, or even people who have newly come into senior roles, but, you know, and are responsible maybe for providing supervisory support to persons in junior roles who are, and it's qualified persons supporting qualified persons. I suppose in terms of that, carving out that time, are there any particular measures that help in that regard? From a
it's a very good question, because how your colleague here says, how did the medical profession address time for training all levels of staff? I have to say that it probably hasn't. I mean, if you want the short answer, we're not very good at it. And even where we try to do it, so there's a new programme out in surgery called Improving Surgical Training that's been piloted across Scotland. And one of the things inherent in that is giving trainers more time for training. But although it's a policy, the reality hasn't really changed. So a lot of it is about snatching time. And I'm sure this seems familiar. So saying to your trainee, walk down the corridor with me and we can go over that case while we're walking, when you're going from A to B. Or that 2 minutes that you have between patients, going, okay, what did you think was the most significant thing then? So there is a phrase for it, but that kind of snatched moments can help, because actually carving out formal time is quite difficult. But then as a department, if there's CPD time, some of that can be education focused. It doesn't need to be purely clinically focused.
Yes, yeah, and being very, I suppose, innovative in a way, and kind of very alert to every opportunity is important. And I see what you mean, kind of really trying to build it in as best you can, but recognizing that, of course, there are still challenges in terms of being able to very neatly carve out chunks of time, that it's in some ways as it arises, but being alert to it, the opportunities as they arise over the day. Really interesting comments coming in here. Kathy making a point, to hear that. Agree, it's shocking to hear that's how things are done around here, and we've always done things that way, I suppose, in this day and age. So, but interesting that it's still there. Just a person here saying, I'm interested in getting the balance between autonomous decision making and sufficient, or getting right the balance between, you know, the student being able to autonomously make their own decisions and manage their own practice, and providing sufficient supervision and support. Did that come up in your research?
It hasn't come up in what I've done. We didn't look specifically at that. It's a very good question, but I'm afraid it's not something I know a huge amount about. And maybe one of your later speakers will be better qualified to comment on that than I am.
I think, actually one of the talks this afternoon might help in that regard, balancing support with supervision and autonomy. And I suppose just another question here, just we have in some disciplines here practice tutor roles who support students and educators in the clinical setting. Medicine may not have exactly the same, but is there any role like that to support trainees, somebody who's sort of designated as a person to specifically support practice education? And has it, does that exist? Has it come up in the research, and what, if any, impact was there of it?
So you're right, medicine doesn't really have something equivalent to the practice tutor role, and I'm aware that that's commonplace in other specialties. But there are still people who oversee training in the clinical workplace. Usually, you know, you've got your university person or your NES link person, but there will be educational supervisors as well as the clinical supervisors. So the clinical supervisors are the ones that are looking after the students. The education supervisors are those that are trying to kind of have the overview of what's going on. Do they contribute to a positive educational culture? Yes, they can. But sometimes they're so overwhelmed by the service and the other demands that there's very little that they can do. But certainly the emergency medicine story, it was the education, the TPD, the training program director for emergency medicine, who was the one that was like, enough is enough, we have to sort this. We have to, and he was the one that started, he started conversations with the trainees because there was a real sense of us and them. The trainees were on one side of the fence and the consultants and the other staff were on the other side of the fence, and they just, you know, the relationships between the two groups were terrible. And he was the one that said, right, we need to talk. And that's how it started, by trying to show the learners that they were going to try their best to support them, but everybody needed to work together on it. So they had to break down these cultural barriers that had built up, that had made it such an unpleasant place to work. So talking, and I know it doesn't sound terribly scientific, but actually talking to your tutors, talking to your learners and saying, okay, what can we do? What is it that really is problematic? What, you know, what's the worst thing that's happening? Okay, let's see, what could we do about it? You'll never solve everything, but try and pinpoint the thing that might make the most difference.
Yeah. I think that's actually such a wonderful point. And even just thinking about finding your students that have finished up here recently, and, you know, for me over the last couple of years, thinking about these particular group of students, and you're kind of concerned about all the challenges that are there for them. But actually, you know, their feedback was extremely positive to external examiners about the support they had on the program. And sometimes I think that's such a good point, is that maybe not everything is perfect, but if you're acknowledging that with students and kind of really demonstrating that you're trying, and like that you're trying to head off the most challenging issues that are arising, something that, you know, creates a culture of kind of almost more like togetherness, or we're in it together and we're all trying and we're all working in the same direction, and there's just that sense of collegiality, and that can help enormously, I think. Yeah.
Absolutely. And I mean, let me see,
yeah.
Sorry, I'm just flicking through them.
I think actually, yeah, it's wonderful to see all of the comments there. My daughter, that's interesting, she gets very negative messages from her placement. A midwife kept suggesting to choose a different career. It's not the first time, and she's only in first year.
Yeah, I mean, how to ensure you don't recruit to your profession is start getting the negative messages. We always used to laugh about our general practice colleagues who would talk endlessly about how dreadful everything was. And I was like, so you talk about how awful it is in front of the students, and then you wonder why nobody wants to do general practice. Have you ever kind of connected the two events? And they were like, But it really, really doesn't help. And I think it is challenging as a cynical, well, no, I don't do any clinical work now, but you know, that kind of, oh God, here we go, it's another day, or there's another challenge, or you do get worn down. But it's actually one of your jobs as an educator is to protect the learners from that, because, you know, you can't recruit people if they think it's awful. They will walk, they will go and do something different, and then that perpetuates the problems of recruitment and retention and so on.
Yeah, that's such a wonderful point, I think, to end on, in some ways, that it's not that maybe you're trying to hide the challenges from the students, but you're not, but I think being very, very careful about how you verbalize them, and I think showing students how you can make your own contribution to the system and make it and enjoy your career, you know, with challenges being part of that, and challenges creating a very interesting part to your career, not just something, I think, that's off-putting. But it's you know, that's such an important comment, I think, from that attendee, and just how important, verbally, what we're saying and implying to students, how that's picked up and passed on. So and you're mentioning the word of mouth piece as well, that's all part and parcel of it. It grows legs.
I know we're running out of time, but there was a comment here from somebody about the exposure. Angela McGrath, encouraging increased participation amongst clinicians to take students. And I think that one lever you have is that you can say, you know, if you take students and they have a positive experience, they will be more likely to come back and work for you in the future, and they'll be more likely to tell their friends that this is a good place to work. And it's that focus on the long-term gains, because I think as clinicians, we're only trying to get through each day. And if you can think, okay, longer term gains, then especially in departments that are struggling to recruit, they're probably more receptive to that. I mean, there will be urban departments that don't struggle and really don't think they need to worry too much, but you know, things change. But it's that, if your trainees, your students have a positive experience, you will get payback in the longer term.
Yeah. Absolutely. I think interesting even that within your own statistics there are figures that, you know, geography wasn't always the single most important thing that determined where someone went. And sometimes I suppose we can feel if students brought in for training aren't from the area that they're training in, they'll never come back. But obviously, to say there's multiple factors influencing what would encourage persons to come back to a placement setting. So it's good to have the big picture in mind. I think that was a wonderful presentation, and I think such great comments there from everybody listening. So thank you so much, Jen, for Jen. I really appreciate that. That's great. I think.
Thank you for inviting me. It would have been much nicer to be back in Ireland, but you know, needs must with COVID. So, and thank you everybody for the questions. It's always really, it's really nice to be able to be interactive, not just to give a PowerPoint.
Absolutely. You know, I think, and it's such an important topic now more than ever, as we're all thinking about how to attract and recruit and retain staff. So no, it's wonderful to have this.
So I shall leave you, but enjoy the rest of your day.
Thank you. Thank you so much. Yes, take care and enjoy the rest of your day.
Thank you.